Chapter 5. The water is filthy and there's no place to live. Que coule trompe soleil, mal pas trompe la pluie. The house that leaks can fool the sun, but not fool the rain. Haitian proverb. The sisters were perplexed by Ricardo's condition. Although being treated for tuberculosis, he languished, a 2-year-old tipping the scales at 15 pounds, underweight even by Haitian standards. Ricardo was a beautiful child with curly brown hair and bronze skin. As his mother was jet black, I suspected his father was either white or mulatto. Ricardo never smiled and howled in pure terror whenever I approached him. Having exhausted all therapeutic options, I gave him a blood transfusion. Within 2 days, he developed a ravenous appetite, gobbling every morsel within reach and howling until he received more food. Several weeks later, he was an ebullient 25-pounder, jumping about his crib and scrutinizing everyone who entered the children's home. He always recognized me, pointing his finger at me while yelling a distinctive gibberish and laughing uproariously when I tickled him. He had forgiven me for sticking needles into his arms and pushing tubes down his throat. He was so popular that the sisters allowed him to stay an extra month. Eventually, his mother took him back to her home. 1 month later, the mother was in a food line without Ricardo. When asked, she sullenly reported that Ricardo had developed diarrhea and died. The sisters were devastated, one of them confiding in me that she questioned the sense of her mission. She had spent several sleepless nights keeping Ricardo alive. Unfortunately, Ricardo's story was typical. The day will come when policymakers realize that no numbers of doctors can eradicate diseases without addressing the underlying conditions that precipitate them. The number of faucets in a country is a more accurate health indicator than the number of doctors. Medicine cannot solve social problems. When 12 people live in a one-room house using the same cup to drink water that comes from a well that contains raw sewage, no amount of medicine will prevent rampant illnesses. Because of poor housing and abysmal sanitation, typhoid, tuberculosis, worms, scabies, and hepatitis were at epidemic proportions. Failure to drain Haiti's swamps made malaria rampant. The biggest killer was tuberculosis. Before coming to Haiti, I had seen 2 cases, but here I saw thousands. Half the patients at Sanfi were afflicted by it. Before antibiotics, tuberculosis was greatly feared in the United States. Those who contracted it had fewer rights than a rapist and were sentenced to sanatoriums. Upon seeing its complications, I understood why. Teresa Lewis, an attractive 30-year-old woman, eked out her livelihood selling food at the market near the children's home. For over a month, she had had a cough accompanied by high fevers and difficulty breathing. She ignored these problems until one day, while spitting, a habit of Haitian women, she saw fresh blood in her sputum. This brought her to me. Her diagnosis was straightforward, as she had the common signs of tuberculosis: anemia, enlarged lymph nodes, clubbing of her fingers, and fluid in her lungs. I confirmed it by examining her sputum under the microscope and seeing the characteristic bacteria. She was taken to Sanfi and placed on anti-tuberculosis medicine. Within 2 weeks, her lungs were free of fluid and the fevers stopped. She returned to her job at the market, continuing her medicine. 4 months later, I was walking near the children's home and I heard a woman shouting, "Dr. Joe, Dr. Joe." The Haitians called me this as my surname was unpronounceable. I immediately recognized Teresa Lewis. Wearing a flowing green dress with a red bandana, she was more beautiful than I remembered. I grabbed her tightly and kissed her on the cheek. She was proof I was helping someone. I asked her if she still took her medicine, something she adamantly confirmed, showing me her pills. She made small talk, graciously complimenting me on my improved Creole and asking how long I planned to stay in Haiti. I bought some peanut brittle from her 13-year-old daughter, giving her a gourd. Teresa Lewis presented me with the appropriate change. Because I had cared for her, she did not overcharge me, even though she saw me pull $30, a small fortune, out of my pocket. Not all cases of tuberculosis had such a happy ending. The causative bacteria are spread by the respiratory route and expelled into the air with each cough. Entire families, especially when debilitated by malnutrition, become infected. Haitians exacerbate the problem by closing the windows and doors of their crowded domiciles at night to keep out evil spirits. The stigma of tuberculosis prevents many patients from seeking health care, as it is assumed they have broken God's laws to deserve such a fate. Blacks, unlike whites, have poor natural resistance to tuberculosis. Whites have lived with this disease for millennia, and a strong immunity has evolved. Blacks, on the other hand, first encountered tuberculosis when they were enslaved 500 years ago. Untreated chronic tuberculosis may fester in a white for years, even decades, but it kills a black man in a matter of months. Tuberculosis starts in the lungs because the bacillus is aerobic, oxygen requiring. Once established, it proceeds to render the patient miserable with an annoying cough. As it progresses, the infection erodes through blood vessels and the patient coughs up blood, like Teresa Lewis. It destroys lung tissue and causes the lungs to fill with fluid, resulting in shortness of breath. The fevers begin in the late afternoon and break during sleep, accompanied by profuse sweating. Appetite is diminished, and the patient rapidly loses weight. If attacked early, tuberculosis can be contained to the lungs. If not, any organ is fair game: the kidneys, skin, brain, eyes, even the heart. Tuberculosis patients become anemic because their debilitated state prevents the bone marrow from making enough red blood cells. When I first arrived, I quantified the anemia by using a hemoglobinometer, a device that determines the concentration of red blood cells in the blood. I quickly discarded it when I learned to estimate the severity of the anemia just as accurately by examining the patient. The skin, even in blacks, becomes pale, especially in the creases of the palms of the hands. The inside of the eyelid, the conjunctiva, turns from its usual red to white. Routinely, I saw tuberculosis patients whose black skin had turned to white, and anemia so severe that it was barely compatible with life. The only way to definitively diagnose tuberculosis is to culture the causative bacillus on agar. Since my lab was poorly equipped, I employed the second best test, a microscopic examination of the patient's sputum. The patient had to cough hard so that the sputum came from the lungs. Getting saliva from only the mouth was useless. The sample was then smeared on a glass slide and allowed to dry. After application of several stains on a specimen, the tuberculosis bacteria appeared bright red in an iridescent blue background. This test also could be employed on other body fluids such as fecal material, spinal fluid, and pus. Another test for tuberculosis was a Ppd Skin Test, purified protein derivative, and is a part of the actual tuberculosis bacillus. When a patient has an exposure to tuberculosis, the body responds by making antibodies to combat it. After the infection is eradicated, the body retains the ability to manufacture these antibodies rapidly if reinfected. When a Ppd is injected under the skin, these antibodies attack, resulting in the skin around the injected site to become red and elevated. This test is used to screen preschoolers in the United States. At first, I thought the Ppd would be an ideal test for diagnosing tuberculosis, but soon I found it to be worthless. Everyone in Haiti had been exposed, so everyone had a positive Ppd. One woman's arm puffed up like the Michelin tire man. It did not exactly inspire her to have much confidence in my ability. The only patients with a negative Ppd were those with end-stage tuberculosis who were too sick to manufacture antibodies. Treating tuberculosis was more challenging. It is an act in itself, requiring a careful history of previous therapy along with an intensive effort to educate the patient in the anti-tuberculosis regimen. Health personnel in the Third World have developed various protocols reducing the misery of tuberculosis until improvement in the economic condition allows suitable housing and sanitation to contain it. The first line of attack is to administer 2 drugs so that if the bacteria evolve resistance to one, the other is still available. In Haiti and most of the Third World, these drugs are isoniazid and thiacetazone. They are inexpensive. isoniazid costing only 1 cent a pill, and thiacetazone available for much less, 100 pills for 1 cent. The cost of saving a life is only $4. Unfortunately, there is a catch. Thiacetazone is a lethal drug, killing almost 1% of people because it causes a hideous allergic reaction, Stevens-Johnson syndrome. From a public health point of view, though, thiacetazone saves more than it kills. It is the only anti-tuberculosis drug the third world poor can afford, so it is either thiacetazone or nothing. However, I found public health semantics to be of little comfort when one of my patients died each week from Stevens-Johnson syndrome. First, the skin would begin to bubble up, covering the patient with welts from the face to the feet. These welts then burst, and the skin literally peeled off the patient's body, exposing a raw, bleeding, painful layer of subcutaneous tissue. Meanwhile, the lips and eyelids ballooned, rendering the face into an amorphous orb of featureless raw skin. The patient is now blind, unable to eat or drink, and in such pain that any movement is torture. Haitians are not complainers, and the patients afflicted with this horror accepted it with a quiet dignity until an inevitable infection killed them. In the United States, Stevens-Johnson syndrome has a 15% mortality, but in Haiti, it was 100%. Initially, I worked hard trying to save these patients, but it was an exercise in futility. I administered the proper treatment, intravenous hydration, antibiotics, steroids, and nutrition via a nasogastric tube. They still died. These patients also needed constant nursing care involving meticulous wound care with sterile technique, turning to prevent bed sores and constant reassurance, and this I could not do. What I could do was replace thiacetazone with another pill, ethambutol. Although more expensive, it combined with isoniazid produced many cures with few side effects. It was gratifying to see my etiolated, anemic, coughing patients become healthy in a few months. Then the real battle begins. Tuberculosis patients have to take medicine for a year after they feel fine. The tuberculosis has not been eradicated, only beaten back and plotting to return at the least opportunity with the vengeance of an army that has lost the battle but has no intention of losing the war. Even educated patients rarely take medicine when they have no complaints. This is the reason public service advertisements urge those with high blood pressure to comply with their treatment. High blood pressure has few symptoms until the patient has had a devastating stroke or heart attack. Until that time, few people see any sense in disciplining themselves to take an annoying pill 4 times a day, especially if it has side effects. Talking Haitians who feel healthy into taking medicine that can consume 10% of their income is impossible. Therefore, the sisters devised a clever system to encourage compliance. They not only gave the medicine free, but also bribed them. Every week, when the patients returned to get their medicine, they also received food and milk. Even if they saw no sense in returning just to get pills prescribed by some crazy blonde doctor, there definitely was merit to getting free food. I reinforced the need to take the pills, explaining they still had tuberculosis and failure to comply would mean death. I was not exaggerating. Haiti was full of people with partially treated tuberculosis, and when it recurred, the cheap drugs no longer worked. They required the big guns, streptomycin and rifampicin. And if these were unavailable, they died. Naturally, these drugs were expensive, especially rifampicin, which cost 50 cents for a daily dose. Nobody donated this drug. When visitors asked what I needed, I always replied rifampicin. People offered to donate the electrocardiogram machines, surgical instruments, and other worthless items. I replied, I want rifampicin. Finally, Andrew Simone pulled several $1,000s out of his own pocket and purchased the drug. I wrestled with drug-resistant tuberculosis daily. Elda was a perfect example. She had been treated 3 times with assorted drug regimens, including rifampicin and streptomycin. streptomycin. As soon as symptoms abated, she did not bother to continue her medicine. Now she was at sans fee, and her fevers and cough continued, no matter what I tried. Finally, she left, telling me she was going to try a combination of milk and orange juice, one of Haiti's many folk remedies. I did not argue, since it could not be any less effective than my treatment. 1 month later, I was rounding at the depot when I heard, "Dr. Joe, Dr. Joe." When I turned around, there was poor Elda lying on the ground. When she had left sans fee, I thought it would be impossible for her to lose more weight. I was wrong. Elda was literally a living skeleton with her taut skin stretched across her prominent ribs and cheekbones. Her arms and legs were so wasted I could identify the individual bones. This is why the old textbooks called tuberculosis consumption. Even well-nourished, Elda would not have been attractive, which is why she had earned her living begging instead of prostitution. "Mapmori, I'm dying," she informed me. Knowing I could not save her, she only asked me to bring her to sans fee and let her die in a bed. Before placing her in the depot, the doctors at the hospital had taken a chest x-ray. Her entire lung field was covered with small oval white flecks, each representing a pocket of pus. Elda had miliary tuberculosis, so called because the white flecks looked like millet seeds. The most feared complication, it means that the tuberculosis has entered the bloodstream and spread through the body. Treatment was futile. In spite of her condition, Elda and I had a friendly chat, but by the time the sisters took her to sans fee, she had irreversibly deteriorated. She surrendered her spirit when she knew she could die in a bed. She no longer recognized me, ranting and shrieking incoherently. When I asked the other women what she was saying, one replied, "Les gens tête chaud," she's crazy. Either she had tuberculosis meningitis or her blood pressure was too low to perfuse her brain. I pharmacologically comforted her with a liberal dose of Valium, allowing a peaceful death several hours later. The key to curing tuberculosis was an accurate history of previous therapy. For example, a patient may have an incomplete course of isoniazid and thiaclidazone at a rural missionary before moving to Port-au-Prince. 2 years later, the cough and fevers return and he comes to our clinic. Chances are his case is resistant to isoniazid and thiaclidazone, so I had to choose 2 other drugs such as ethambutol and rifampicin when available. If he failed to complete this course, he would end up like Elda. To my surprise, the Haitians knew the names of the medicines they had taken. Occasionally, a patient had forgotten, but I could find out by quizzing him on the color of the pills. Tuberculosis caused a slow death like cancer and made the patient miserable by impaired breathing. One man at sans fee, Eugene, had tuberculosis but otherwise seemed healthy, with good muscle bulk and a hearty appetite. However, he was breathing too rapidly. When I listened to his lungs, the right side had normal breath sounds, but on the left side I heard nothing. Using percussion, I ascertained the right side was full of air, but the left side sounded dull. The left lung cavity was filled with fluid, a pleural effusion, a frequent complication of tuberculosis. The best treatment is to ignore it, since it will resorb as the underlying disease is cured. However, this man's effusion was huge and making him uncomfortable. It had to be removed. The procedure to remove a pleural effusion is called a thoracentesis. First, one obtains a chest x-ray to confirm the diagnosis and then drains the fluid by inserting a needle into the lung cavity. The danger is that the needle can puncture the lung, lethal in a patient with severe lung disease. Consequently, I approached Eugene with caution and trepidation, especially since I had no x-ray equipment and was relying entirely on physical examination. In the United States, this would be considered gross malpractice. Fortunately for Eugene, I had done many thoracenteses as an intern and had no difficulty hitting the effusion. I stuck an angiocath directly above one of the lower left ribs and pulled out the stylet, leaving only a plastic catheter in the lung cavity. This prevented puncturing of the lung as it re-expanded. 20 minutes and 3 quarts of fluid later, Eugene was breathing easier and thanked me profusely. Thoracentesis became so routine at sans fee that I soon had Day and Nick doing them. Nonetheless, visiting doctors raised their eyebrows when they saw one of us plunge a needle into a patient's chest without the benefit of an x-ray. When I first arrived in Haiti, I would not subject a patient to the potential side effects of anti-tuberculosis medicine unless I espied the bright red bacillus under the microscope. But when I witnessed the suffering this disease caused, I changed. Any patient who had a cough and fever for over a month had tuberculosis until proven otherwise. If I heard wheezes in the lungs, felt an enlarged neck lymph node, or saw clubbing of the fingers, I started the medicine. It was impractical to look at the sputum of all tuberculosis suspects. Dozens of diseases such as lung cancer, sarcoidosis, or fungal infections had similar symptoms, but I lacked medicine to treat them. Thus, I rationalized that the sin of omission was worse than giving anti-tuberculosis medicine to a few patients who did not have the disease. This represented a complete reversal of my medical philosophy. American physicians are trained to have a diagnosis before giving treatment. There is nothing worse than causing a nasty side effect with an unnecessary medicine. Also, starting a medicine prematurely can obscure a diagnosis. For example, treating a patient with antibiotics makes it more difficult to culture the causative organism. But in Haiti, all the rules changed. The best test was to see if the patient responded to the medicine. Nowhere was this truer than with the children. Many were like Marie Helena, who was losing weight after having fevers for no apparent reason. I had examined her multiple times, failing to find a cause. Then I randomly tried various antibiotics with lackluster results. I even treated her for malaria, although I never saw the causative parasites in her blood. The fevers continued. After exhausting all possibilities, I only had one thought remaining: tuberculosis. I managed to obtain a chest x-ray from one of the local hospitals, but it was normal. I even put a nasogastric tube into her stomach several times, examining the aspirate for the characteristic bright red bacillus. Even in distress, Marie Helena was a gorgeous child. With her CoverGirl chocolate skin and curly black hair, she was the darling of the children's home. She had the most toys in her crib, and there were polite discussions amongst the visitors over who should feed her. One visiting doctor practically adopted her, feeding her, changing her, dressing her, photographing her, everything but figuring out what was wrong with her. Finally, I bit the bullet and treated her for tuberculosis. She did not even have a cough. Within a day, her appetite improved, and soon Marie Helena was eating like a little pig. The fever stopped, and she became even cuter, something I did not think was possible. With some meat on her bones, she was a true prima donna, a corpulent, temperamental darling pampered by all. Her case taught me that tuberculosis can masquerade as simply failure to thrive, nothing else. I was constantly amazed at how many children with failure to thrive responded when I shot from the hip and administered anti-tuberculosis medicine. Attempts to vaccinate against tuberculosis in Haiti have been fruitless. In the United States, tuberculosis was the leading cause of death at the turn of the 20th century, but its incidence has gradually declined. Surprisingly, the anti-tuberculosis medicines invented in the 1940s had little effect on the declining rate. The improvement of economic status, along with the concomitant changes in housing and sanitation, was the main factor. Tuberculosis still persists in the inner-city ghetto population and will remain as long as the ghetto remains. The Haitians were also bothered by minor but extremely irritating afflictions they contracted because of their close living quarters and frequent body contact. The worst of these was scabies. I could empathize with my patients since I contracted it 4 times. Once called the 7-year itch, scabies could not have been invented even by the most imaginative sadist. When it first attacked, I found myself occasionally scratching my wrists, a small nuisance. My scratching then spread up my arms to my armpits, then my legs, and eventually my entire body. Showering made the itch worse, and when it was full-blown, uninterrupted sleep became impossible. I woke up in the middle of the night violently scratching everywhere. Scabies is caused by a hideous mite with 4 pairs of legs and massive pincher-like jaws that it uses to burrow into the skin. The diagnosis can be made by scraping a suspected skin lesion and finding this miniature monster under the microscope. In medical school, my dermatology professor told me that allowing the skeptical patient to view this creature encouraged compliance with treatment. This mite, when situated, then lays eggs, the reason scabies persists indefinitely when untreated. Unlike the poor Haitians, I had the solace of knowing I would be cured with treatment. Every day at the clinics, I saw many patients with gratel, itchiness, who had hideous cases of scabies. They had huge scratch marks along their armpits and on their arms. The mite invaded the skin between their fingers, where they clawed themselves in a futile attempt to obtain relief. The scratches bled, and the unfortunates who had had scabies for years had telltale scars. Some scratches developed secondary bacterial infections requiring the addition of antibiotic treatment. Scabies is cured with a lotion called Quell, but the relief is not immediate. The itchiness is not caused by the mite itself, but rather by the allergic reaction to it. Therefore, a dead mite is just as annoying as a live one. While the lotion kills the mite, a month of constant skin turnover is needed to eject its corpse. All clothes and bed sheets must be washed to prevent reinfection. The poor Haitians lacked the necessary sanitary facilities, and I doubt if I cured many cases. At least 80% of the Haitians had scabies, and it was especially disheartening to see the starving children also being tortured by these little beasts. The redeeming quality about scabies is that it was not lethal, unlike another disease I frequently encountered, typhoid. Along with malaria and yellow fever, typhoid helped Haiti win its independence when it ravaged the invading French army at the turn of the 19th century. It continues to ravage the Haitians. Michelle was a young woman brought from one of the clinics to Saint-Fie. She was lying in a bed with high fever when I met her. Michelle was not a complainer and would have refused our hospitality had she not been penniless and unable to walk. She had a severe headache, abdominal pain, and diarrhea. Her exam showed little more than diffuse abdominal tenderness and anemia. I considered typhoid, along with tuberculosis, malaria, or a viral diarrhea. The fever never defervesced. This confirmed typhoid, as both malaria and tuberculosis have intermittent fevers. To the astute physician, this reasoning represents poor judgment at best and gross incompetence at worst, as there are hordes of other problems that have an identical presentation. For example, appendicitis has a similar appearance, but since I did not have the necessary surgical equipment, there was little sense in considering this possibility. I treated her with the antibiotic chloramphenicol. Typhoid is caused by a bacterium that calls the human digestive system its home. There it invades the intestinal mucosa, causing diarrhea. With each bowel movement, it is excreted, and in Haiti, it finds its way into the food and water supply, where it reinfects others. Later in the day, a Haitian woman began screaming for me to examine Michelle. I walked over and saw an overflowing bedpan full of fresh blood where Michelle had just defecated. Michelle had just perforated a blood vessel in her intestine, the most feared complication of typhoid. She had verified my shaky diagnosis in the worst possible way. Quickly, I found a bottle of normal saline and placed an intravenous line in her arm. The saline poured in, but the blood continued to ooze out of her rectum. I had no blood to give her. Michelle appeared nonchalant as she faded out. The terrified look that I had become accustomed to seeing daily never crossed her face. Perhaps she welcomed death. Her last earthly view was that of a frustrated blonde doctor helplessly peering at a bottle of saline. The typhoid bacillus was not the only inhabitant in the Haitians' intestines. They also had worms. Although they rarely caused fatalities, these creatures infested the vast majority of the Haitians and literally sapped them of their blood and energy. There were different species of worms, and I had learned to identify them by the appearance of their eggs in stool specimens. It was a skill I soon forgot, since I only had one deworming medicine available and saw little sense in performing an academic exercise that did not change the therapy. One of the more common worms was the hookworm. The immature forms, or larvae, enter the body by burrowing through the soles of the feet of a shoeless patient, causing an annoying itch. They are transported to the lungs via the bloodstream and lymphatics, resulting in a cough as they crawl up the windpipe. They are then swallowed and enter the intestines, finding a permanent home upon anchoring to the mucosa with their 4 sharp teeth. They feast on blood, rendering the poor patient anemic. Upon reaching adulthood, they lay thousands of eggs that are excreted in the feces. The eggs hatch in the soil and infect another shoeless patient, completing the cycle. Another common worm was Ascaris, but unlike hookworm, it is spread by directly ingesting its eggs that are found in the soil. Many of the children had geophagy, which means eating dirt, a child's natural response to intractable hunger. As the Haitian proverb goes, Mashwe branen grand goût chule. Chewing anything helps to chase away hunger. Yeah, that's right. These eggs also contaminated the water supply and were even found in breast milk. Ascaris did not feed on blood, but skims the food its congenial host is digesting. They can grow to be a foot in length and can block the intestines, a surgical emergency. These worms migrate through the body, causing abscesses and pneumonia. Like flies, worms did not bother the Haitians as much as they did me. The mothers routinely saw worms when they changed their infants' diapers. They had folk remedies to eliminate them, but were not upset when unsuccessful. Rarely did a patient come to me complaining, "Moi ve, I have worms." To the Haitians, having worms was simply part of life. Both hookworms and Ascaris were easily treated by giving a drug called piperazine. Every child who entered the children's home was dewormed, and a child excreting a worm 1/3 its length was a common sight. Occasionally, a child would pull a worm out of his mouth. The sisters seemed to take a sadistic delight in showing them to squeamish visitors. Another common disease, malaria, was caused by a smaller but more dangerous parasite. The name means bad air in Italian, as early Italian physicians speculated that it is spread through this medium. They were close. The parasite is injected into the bloodstream by the Anopheles mosquito, a large insect that hovers like a bomb-laden airplane, circling until finding some poor person to bite. Usually, I refused to take medicine, but these mosquitoes intimidated me into complying religiously with the prophylactic antimalarials. When a human is bitten by an infected Anopheles mosquito, the immature form of the malaria parasite enters the blood and is absorbed by the liver cells. There they rapidly reproduce, bursting through the cell wall into the bloodstream, whereupon they enter the red blood cells to feed upon hemoglobin, the protein that carries oxygen. They again reproduce, and when they break out of the red blood cells, the patient spikes a fever. These new parasites then find more red blood cells, restarting the cycle. The human host responds by making antibodies which, in their quest for the parasite, destroy the red blood cells, causing severe anemia. Haitians, like blacks in general, have a high natural resistance to malaria because the disease has existed in Africa for eons. The development of sickle cell anemia is an evolutionary attempt to avoid malaria, and those with sickle cell anemia have less severe symptoms when they contract malaria. Jean was a typical malaria patient. He presented during the peak of the rainy season when the mosquitoes were breeding rapidly, along with 10 others that day with the same symptoms. He had la fièvre, a mal tête, fever and headache. He accurately described how the fevers came, first with a wicked chill that made his teeth chatter, followed by a profuse sweat that left him exhausted but relieved. He felt fine for several days until the fever returned. Jean did not need me to diagnose his problem. He knew he had malaria and just wanted me to give him the medicine, chloroquine. I had a conservative approach when giving this drug. In many third world countries, especially in Southeast Asia, chloroquine has been dispensed like water. The result was predictable. The malaria parasite evolved resistance to the drug. Now in these countries, treating malaria is much more complicated and requires giving several drugs together, subjecting the patient to dangerous side effects. Fortunately, chloroquine-resistant malaria has yet to be reported in Haiti, and I was doing my part to maintain the status quo. All malaria suspects had their blood examined to make a positive diagnosis. A drop of blood was smeared on a slide to dry. This slide was stained with a solution that lysed the red blood cells while keeping the parasite intact. If the patient had malaria, I found colorful red-purple signet-shaped parasites under the microscope. Sometimes I had to look for 5 minutes, but if I did not see the parasite, I did not give the chloroquine unless the patient was severely ill. Whites who had foolishly stopped their weekly prophylactic chloroquine also contracted malaria and found their way to my care. Since they do not have the same natural resistance, their symptoms were more severe than the Haitians, and some were close to death. Everyone improved, but I did not have malpractice insurance, so I avoided treating Americans. It is truly a sad state of affairs when the first thing one thinks of when looking at a sick patient is one's liability. Malaria is a pleasure to treat because the patients improve quickly. By being given 5 white pills, a febrile, exhausted human being was transformed into a happy, energetic individual in a matter of days. Few diseases have such dramatic results with simple treatment. The key to success was patient education. I spent hours instructing my patients on how to take the medicine and then having them repeat the directions until I was satisfied they understood. Since the vast majority were illiterate, I would take a piece of paper and draw a picture of the sun rising, the sun high in the sky, the sun setting, and the moon in the sky. Each picture represented a time of day. Then I would draw a sketch of the pill under the appropriate scene so that the patient knew when to take the medicine. Malaria patients often become nauseated and regurgitated their medicine. One of the good sisters almost died because she could not keep chloroquine in her stomach long enough to be absorbed. I had to administer her medicine intravenously before she began to recover. Not all patients with malaria had typical symptoms. Jarette, an 8-year-old girl admitted to the children's home with severe malnutrition, was one of these inconsiderate individuals. She had no fevers, headaches, or abdominal pain, but each day she became more visibly anemic, her dark skin turning to café au lait. Because she had no appetite, her body became too weak to mount a fever. Her only request was that she not be harassed by compulsive blanc doctors. Her blood was replete with parasites, including the mature forms that indicate a chronic disease. With chloroquine, she improved so quickly that I thought it was voodoo. The sisters sent her to school since her family could not afford it. Because of her case, I screened every child admitted to the children's home for malaria. While malaria typically caused fever and anemia, a chronic infection sometimes resulted in kidney failure. The sisters brought a young man to Saint-Fie. He had a bloated face, distended abdomen, and swollen legs. A microscopic examination of his urine showed hemoglobin casts, columns of coalesced red blood cells indicating kidney destruction. His blood was full of malaria parasites. With chloroquine, he slowly lost the excess water as his kidneys began to function. His balloon-like face developed eyelids and cheeks, returning to its normal appearance. The worst complication was when malaria entered the brain. Doing battle with cerebral malaria was a fight I rarely won. While I was rounding one Sunday, a missionary priest arrived with an anemic, comatose, muscular young man who was dying. The priest told me he was walking and talking the previous day, but had complained of fevers and severe headache. He had changed mental status, an indication for an immediate spinal tap to rule out meningitis. Day deftly performed the procedure, and when he pulled out the stylet, the spinal fluid gushed out rather than dripping slowly as usual, indicating increased pressure. His blood was full of malaria parasites, but the spinal fluid was clear. This meant that the malaria had inflamed his brain, causing the spinal fluid pressure to increase. There went the afternoon. Actually, my health was spared by caring for this patient. The only time I did not work was Sunday afternoon when I relaxed by playing softball with the Marines who guarded the American Embassy. Being a card-carrying weekend warrior, I found that these games inevitably resulted in my injury, either from spraining my ankle tripping over first base or displacing my front tooth after plowing into a Marine twice my size while chasing a fly ball. In all my stay in Haiti, I never got seriously ill, although I treated the worst diseases on the planet. However, I barely survived these violent softball games. This gentleman, whose name I never learned, died in spite of my best efforts. His coma was so deep that he would not respond to the most noxious stimulus I knew, a ringing tuning fork on the nose. My only success with cerebral malaria was a woman who came to me, still conscious, who described perfectly having brain-crushing headaches and high fevers. She also had a high pressure when Nick did the spinal tap, and her blood was full of parasites. Not only did I give her steroids and chloroquine, but as she was nice enough to come on a weekday, I could get blood from the Red Cross in downtown Port-au-Prince. The Red Cross is truly a wonderful organization, well deserving of its Nobel Peace Prize. I was a regular there, and although I transfused scores of patients, no one ever had a transfusion reaction. Even with their limited equipment, their technique was flawless, and they bent over backwards to obtain any blood type I requested. My patient with the cerebral malaria did not respond initially, and after several days of treatment, death was imminent. But then her headache abated, and soon after she developed the most important sign, an appetite. Within 2 weeks, she was helping to clean and feed the other patients, and then left, going back to her world. This patient did well, not only because of the treatment, but because of early diagnosis. Comatose patients with cerebral malaria always died. Like everything else I treated, the solution to malaria was not having doctors dispensing pills. The vector that spreads it, the Anopheles mosquito, has to be destroyed. In a more idealistic era, this seemed to be possible. The breeding grounds were sprayed with the pesticide DDT, and the swamps were to be drained. It just did not work. The mosquitoes developed resistance to DDT, and political factors made swamp drainage impossible. Perhaps the goal was unrealistic. Indigenous malaria existed in the United States until the 1950s, and to transfer this effort to areas that have not developed a representative government is not to be feasible in just a few decades. Malaria, like typhoid, tuberculosis, hepatitis, diarrhea, and the other afflictions I dealt with every day, will not be eradicated soon. Haiti must achieve the economic development that will permit it to afford the necessary plumbing, vaccines, nutrition, and swamp drainage. One thing I learned in Haiti is that these diseases certainly will not be eliminated by doctors.